For those of you who don't know me, my name is Courtney. I'm one of the content creators here at NCLEX Bootcamp. I have been a registered nurse since 2010, which is hard to believe, and a psychiatric nurse practitioner since 2017. So quite a while. Most of my career has been spent in mental health, but before I went into mental health, I worked in med-surg and public health for a number of years as well. So a little bit of experience all over. And we are also joined today by Dr. Amber Adams, who is down there in the chat. So she's moderating today's event, so feel free to pop in and say hi to her. She is going to be dropping some helpful links throughout the presentation, answering any questions you might have. And as you know, today is kind of a live review session, so we're going to be answering some practice questions together. So I might ask you to weigh in on some of the answers, so feel free to leave your answer down there in the chat, just to make it a little bit more interactive, a little bit more fun, so you can kind of think about these questions as we go through them. All right, so should we get started? Are you guys ready? All right, so we're going to cover a few things today. So like I said, today is kind of a live review session for our some NCLEX questions, and we're going to be focusing on single best questions today. And so why, you might ask, are we focusing on single best? It's because these are the most common item type you're going to see on the NCLEX, and they can cover a really wide range of topics. So you might get pharm, mental health, prioritization, delegation, maternity, OB, all of the above, right? So I have handpicked a couple practice questions for us to go through today. And so we're going to talk a little strategy about how to approach those and get a little practice in. So before we dive into those practice questions, we're going to talk a little bit about how these questions are scored. It's really easy. And then we're going to talk a little strategy about how to approach those questions. And then we're going to dive right in and do some practice questions together. And these questions are going to look very similar to what you might see on the actual NCLEX. So let's take a look. So let's first off cover really quick how these items are scored. Like I said, it's really simple. These are the easiest ones to score. So you can see that with single best items, we're going to have 4 answer options, and only one of those is going to be correct, right? So if we choose the correct answer option, you're going to get 1 point. Now, if you get the answer incorrect, you're going to get 0 points. So we call it the 0-1 scoring rule, because you're not going to lose a point, you're just not going to get a point. Okay, so it's either right or it's wrong. There's no partial credit for these questions. All right, excuse me. Okay, so let's talk a little bit of strategy before we dive in, a little test-taking strategy. So people ask me, what is the best advice I can give to someone who's going to take the NCLEX? And I will tell you, my number one piece of advice that I give to everybody that I say is so important is to make sure that you read the header and the stem really, really carefully. And I know this sounds simple, but you would be surprised how easily this can trip people up, because the NCLEX might ask you something like, which of the following actions by the nurse is correct? Okay, so in that means we're looking for one correct answer, and three of those options are going to be incorrect, right? But then we might also get a stem that says, which of the following actions should the nurse take first? Well, that means that all of our answer options are going to be correct, but only one of them is going to be our highest priority that we should do first. And then we might get an even different stem that asks us which of the following actions by a staff member would cause the nurse to intervene, which means it's kind of asking us almost a negatively phrased question saying which of these actions is incorrect. So you can see that if we don't read that header and stem really carefully, we could accidentally answer that question wrong, even if we know the content, which is definitely not what we want to do. So always, always, always read very carefully before you answer the questions. And then when I'm going through questions, I like to read the header and the stem really carefully. And then I like to ask myself, okay, what do I already know about this topic? So for example, say that I got a question, a pharmacology question, and it was asking me about fluoxetine. Okay, what do we know about fluoxetine? You guys can help me out. What do you know about fluoxetine? Let me change my chat here so I can see you. All right, so we know that fluoxetine is what kind of medication? It's an SSRI, right? A selective serotonin reuptake inhibitor, which is a mouthful. And so we know that these are used for depression and anxiety. Can anyone tell me what are some common side effects of SSRIs? Anybody know? I know GI upset, right? They can cause like nausea, diarrhea, headaches are common. Sexual side effects are really common with this class. All right. What do we know about how long these take to work? They can take several weeks to start working, right? And then what's the big thing we worry about with this medication class? Oh yeah, you guys got it. Serotonin syndrome. And I always remember the symptoms of this in kind of a fun way. I always think of sweating, shaking, and strange behavior. So like sweating or fever, shaking or muscle rigidity, and strange behavior, so like changes in mental status, right? Okay, so already we can see we know quite a bit about fluoxetine. So that kind of helps me. I do my brain dump, and that can be really quick, just to kind of a quick run through. And so if I got an answer option that said, oh, the client needs to avoid aged cheeses and wine or tyramine-containing foods, I would say, oh, well, that is true, but it's true for MAOIs, right? Not SSRIs. And so by doing this brain dump, it just kind of helps me to put down everything I know so that I'm not accidentally distracted by like a distractor option that might be true of like a different class of medication. So it kind of helps me keep things straight in my head. Okay, so once I do that, then I start ruling out answer options. Okay, so are you guys ready to do some real life practice? All right, let's go. Okay, so our first question is going to be a prioritization type question. So when we think of prioritization, we're thinking which of these conditions is most life-threatening, right? That's going to be our highest priority. So in this question, we have an emergency room nurse who is receiving change of shift report on the following clients, and we're being asked which client should the nurse see first. So when we're being asked which client we should see first, we're going to be looking for who, right? The client who is at most imminent risk for a life-threatening concern. Okay, so to remind ourselves of how we're going to prioritize these clients, let's take a look at our handy prioritization cheat sheet. And you can find this on NCLEX Bootcamp on our live site as well. It's just a really helpful tool to kind of figure out who we need to see first. So I always like to start over here on the left and work my way over. So first I'm going to eliminate any stable and chronic issues. So the example I like to use for this, and we often see this as a distractor, is maybe a client with COPD who's having dyspnea on exertion. Well, would we expect a client with COPD to have dyspnea on exertion? Yes, we would expect that to happen. It's not good, right? Like clearly this is going to be a health condition that is going to lead to poor health outcomes in the long term. But dyspnea on exertion is expected in the process of COPD. And so if we had a client who was short of breath when they were up walking around, they had COPD, I wouldn't expect that to become a life-threatening concern within the next couple minutes, right? So that's why it's a lower priority. Okay, and then from there we can go over to our green area here. So that's going to be our routine tasks, expected findings, and psychosocial needs. So we often see psychosocial needs pop up in here. So this is going to be things like financial stressors, some kind of emotional distress, like the client's upset about something. And so what we need to remember is we're not saying that these aren't important, because they are. They're really important, right? But they're just not going to cause imminent life-threatening things to happen within the next few minutes, right? So if a client can't afford their medications, we have time to address that, right? It's not going to be fatal within the next couple of minutes. So that's why it's going to be a lower priority, okay? And then from there, we move into our yellow zone, which is going to be our neurological disability, circulation, and breathing, okay? And then our two biggies, which are going to be our airway and safety. And this makes sense if we think about it, right? Because if we have a client with an airway obstruction, how long do we have to intervene before this becomes life-threatening? Minutes, right? Not very long at all. So I have a lot less time to fix an airway issue than I do a financial stressor, right? So that makes sense. And then any safety issues, so anything that's causing an imminent life-threatening risk to the client. So say they have suicidal ideation with a plan and access, and they plan to act on it right away, right? That's an imminent safety concern, okay? So with that in mind, let's go back to our question. And now that we've kind of got our prioritization pyramid in our head, let's take a look at our answer options and see if we can figure this out. Okay, so our first option is a 7-year-old who fell out of a tree and is cradling a discolored and swollen arm. What do you guys think? What do we think might be happening here? I'm thinking probably a sprain, strain, a fracture of that arm. So we definitely need to follow up, right? But is this going to be a life-threatening issue if we don't address them in the next 3 minutes? Probably not, right? But let's take a look at our other options to see if we can figure out if there's anything that's going to be a higher priority. We have a 3-year-old who's been vomiting for 12 hours and has a temperature of 103.6. What do you guys think? That's definitely concerning. I'm more concerned about this 3-year-old than I am about this 7-year-old, so I'm going to rule that one out because I'm concerned about they're vomiting, they have a temperature. What are you guys worried about? I'm worried about dehydration, which could easily become a circulatory issue or a circulation issue. Okay, so right now number 2 is my highest concern, but let's go down to number 3 and see what we have here. So here we have an 18-month-old who's vomiting and was found with an open bottle of drain cleaner. What do you think? What are you worried about? It sounds like they've ingested this drain cleaner, right? They have an open bottle of drain cleaner and they're vomiting. So I think it's safe to assume that they have ingested drain cleaner. And what do we know about drain cleaner? It's really corrosive, right? So we're going to have a lot of tissue damage. And so if they swallowed this into their esophagus, what's right next to their esophagus? Their airway, right? So now we have a corrosive substance that's causing tissue damage and swelling right next to their airway. So what are we thinking might happen? I'm pretty concerned right now about an airway obstruction. Okay, so if they have swelling and edema around this airway issue and it's closing off their airway, how long do we have to intervene? A couple minutes, right, at the most. So I am more concerned now about number 3 than I am number 2 because remember, airway issues are going to come ahead of circulation issues, okay? So 3 is right now topping my list, but let's take a look at number 4. We have a 5-year-old with epilepsy who experienced a seizure 30 minutes ago that lasted 3 minutes. What do you guys think? I think if we look, we could say seizure is probably a neurological issue, right? Which is still not going to top airway. Also, what would be the criteria for status epilepticus? Does anybody know? We'd have to have a seizure that was lasting over 5 minutes, right? And this client had a seizure 30 minutes ago. So there's nothing happening right now that we're being told of. So I think we could say they're fine, right? There's nothing going on right now. Nothing to make us think that there's an imminent risk going on, right? Yeah, so I see a lot of you are thinking number 3 is going to be our highest priority, right? Because we are worried about airway issues with number 3. And I also agree. So should we see if we're right? Yes, we are. And you can see, if you look at how many people in our bank got this correct, it was about 57.4. And so if you got that right, you're doing better than most. So good job. All right, so let's go on to question number 2. So this is a pharmacology question. Does anybody love pharmacology? I know some people say they struggle with this. I like pharmacology, but that could just be me. Okay, so let's see. We have a client with hypertension who's taking lisinopril, and we're being asked which of the client findings is most concerning. So again, this is another prioritization type STEM. So we're saying all of these are going to be concerning, right? But which is the most concerning? So if we're asking which is the most concerning, what are we looking for? The one that has the potential to be most life-threatening, right? Okay, so let's do a little brain dump, and you guys can help me with this. So what do we know about lisinopril? What kind of med is this? This is a ACE inhibitor, right? Angiotensin converting enzyme inhibitor. All right, what do we know about ACE inhibitors? Does anybody know what are just some common side effects in general to antihypertensive medications? Well, we know that they're used to lower blood pressure, right? If it's too high. What happens if we lower blood pressure too much? A lot of clients end up with what we call orthostatic hypotension, right? So blood pressure gets low when they stand up. It can make them dizzy. So we have to tell them to stand up slowly and change position slowly. Oop, I see someone says coughing. Yep, that's a common side effect. Is that usually life-threatening? Or is that just an annoying side effect? Yeah, it's typically an annoying side effect, not typically life-threatening, right? Okay, what do we know is a big concern with this medication class? What's a life-threatening concern that can happen? Oh, I see it. Tosh got it. Angioedema. Good job. Okay, angioedema we worry about, right? Because that is swelling in the face, in the neck, and then what do we worry about if we have swelling going on in this area? Airway obstructions, right? So if we have swelling of the lips and the tongue and in this area, we worry that it could obstruct the airway, right? Which we know, if we go back and look, is going to be our highest priority, right? So let's take a look at our answer options. We already know quite a bit about ACE inhibitors already, so let's see if we can use this to answer our questions. So option number 1 is itchy lips and tongue. All right, what might that be a sign of? Yeah, that might be a sign of angioedema, right? Because if their tongue is itchy and their lips are itchy, that might be because they're swelling, right? So that would be pretty concerning, right? Because like we said, we're worried about airway because swelling of the face could lead to an airway obstruction. Okay, so right away, I'm thinking that's probably most concerning because we know airway issues are a big deal. But let's take a look. We always want to read all of our answer options because we want to make sure we're not missing anything. Okay, a persistent dry cough is number 2. Well, we already said that that is a common side effect. And while it's concerning because it can be an issue for clients not wanting to take this medication, it's not typically life-threatening, right? Okay, so I'm going to say that's not my most pressing concern at the moment. How about a blood pressure of 142/92? Is that normal? No, it's not normal, right? But is it a hypertensive crisis? No. It's high. It's higher than I would expect to see for somebody who is being medicated for hypertension. So that might be a sign that the lisinopril isn't working so well for them. Maybe they need a bigger dose or maybe they need a different medication. But is this blood pressure life-threatening? No. Right? So not my most pressing concern. And how about feeling lightheaded when standing quickly? Is that a pressing concern? Well, we already said orthostatic hypotension is common. And so feeling lightheaded when they stand quickly is probably a result of that blood pressure going low, right? And that can happen with antihypertensive medications. And so we need to educate them, right, to change positions slowly, to stand up slowly, not come bouncing up out of their chair really quickly because that will increase their risk for falls, but definitely isn't going to top a potential airway issue, right? So I'm still liking number 1 as our answer for most concerning. What do you guys think? I see a lot of number 1s. Yeah, okay. Let's take a look and see if we're right. And yes, we are correct. Itchy lips and tongue, right? Because we said we were worried about angioedema, which can be an airway obstruction. And we know that airway obstructions are always going to be a really high priority concern, right? All right. You guys are doing great. Good job. Yeah. Yes, Janice says you don't need to freak out. Just educate. Yes. Good advice. Okay. Let's take a look to number 3. So this is a therapeutic communication question. So how do you guys feel about therapeutic communication? You feeling pretty confident? This is a topic that is really likely to come up on the NCLEX because therapeutic communication isn't just for those of us working in mental health, right? It is applied throughout every field of nursing that we work in. We need to be good communicators. We need to be good therapeutic communicators. So let's take a look at this question. So we have a client who recently experienced a significant loss, and the client states, "I'm doing fine, everything is okay." However, the nurse notices the client is frowning when they're speaking. Okay, so there's a lot going on in this heading. So what do we notice is kind of our problem here? We have something we call incongruent communication, right? So our verbal and nonverbal cues are not matching up, right? So the client is saying everything's fine, I'm good, but their face is showing something else, right? They're frowning when they're saying this. So we're being asked which of the following would be an appropriate response for the nurse to make. So we're trying to get to the bottom of what's happening, right? We need to solve this incongruent communication, right? We need to reconcile these incongruencies we're seeing between verbal and nonverbal cues. Okay, so before we do that, let's take a second to remind ourselves what we know about therapeutic communication. Now, therapeutic communication can be broken down into kind of three big areas. So we have our active listening, our open-ended questions, and our non-judgmental communication. So our active listening is going to be things that we say that just kind of show the client, like, I hear you, I understand, I'm listening, right? So we might kind of reflect things back to them. So if they said something like, oh, I've been up all night, we might say like, oh, you didn't sleep well last night. Okay, I hear you, I understand, right? And that is a good way to show the client that they have our attention and that we're following along. And then we have our open-ended questions, because we all know we typically don't want to ask closed-ended questions. So we want to ask open-ended questions to prompt the client to give us more information. So for example, if I were to ask you, are you studying for your NCLEX? What are you going to tell me? You're going to say, yes, I am. But that's not going to give me much information. So I might ask you, how are you studying for your NCLEX? And that might prompt you to say, well, I'm using Bootcamp and I'm reviewing my class notes and I'm doing these things, right? That's going to give me more information. And then the last thing we want to be mindful is that we don't want to be coming across as being judgmental, because nobody likes to feel judged, right? And so if the client feels like you're judging them, they're not going to want to share with you. So if I, for example, asking why questions can feel judgmental. So just in our previous example, I said, how are you studying for your NCLEX? And you'd say, oh, I'm doing this and that and whatever. But if I were to ask you, why are you studying for your NCLEX like that? That feels judgy, right? You'd be like, ooh, I don't know. Am I doing something wrong? I feel like she thinks I'm doing something wrong, right? And so we don't want to come across as being judgmental. So we don't want to say things like, why are you doing that? But we do want to say things like, yes, I understand. Or we make neutral observations like you seem like you might be feeling uncomfortable, or it seems like this might be happening, or I've noticed this, right? We want to make neutral observations. Okay, so let's go back to our question and take a look and see if we can figure out which is correct. I'm seeing a lot of 1s and a lot of 4s. All right, so let's take a look at our first one. I can see that you're feeling upset. Tell me more about what's bothering you. Okay, I like this. Tell me more about what's bothering you is a nice open-ended question, right? So we're just saying like, tell me more. But there's one thing about this question I don't like. Does anybody know? And this is a tough question. This is a more advanced one. Does anybody know? Okay. The one thing I don't like about this is we're telling them kind of how they're feeling. We're saying, I see you're feeling upset. We're kind of putting words in their mouth, right? We don't want to do that. We don't want to say like, I see you're angry. I see you're feeling upset. I see, we're kind of telling them how they're feeling, which we don't know that, right? We don't want to make that assumption that they're upset. We just want to get to the bottom of this incongruent communication. So I think there might be a better way to ask this. So let's take a look at our other options. Our number 2 says, okay, I understand. If you want to talk more about how you're feeling, I'm here for you. What do you guys think? I mean, it's nice that we're saying that, I'm here for you. That's nice, right? But does that help us get to the bottom of what's going on? We're not asking any questions at all, are we? We're just saying like, okay, that's good. I'm here for you. But that doesn't help us solve our problem of this incongruent communication. Okay. Number 3. I'm glad to hear everything is okay. Is there anything specific you'd like to discuss today? What do we know? What do we see about this one that's not so great? We're kind of just blowing right by those nonverbal cues, aren't we? We're just like, okay, you said everything's fine. Anything else you want to talk about? And this is also what? This is a closed-ended question, right? So if we ask that, what's their response likely going to be? If I said, is there anything else you want to talk about? They're going to be like, no, there's nothing more I want to talk about. So that's not going to get us any information. So let's see number 4. I see a lot of you pick this option. Let's take a look. You mentioned everything is fine, but your facial expression seems to show otherwise. I'd like to hear more about that. What do we like about that? I like that we're just kind of observing what we're seeing. I'm like, you're saying that it's fine, but your face doesn't seem to match. We're not saying that you look angry or you look upset or you look frustrated. We're just saying like, hey, I'm observing that these two things don't match. And then we follow it up with an open-ended question. And what you'll tend to notice with therapeutic communication is it follows a pattern, right? So typically we make an observation, we ask an open-ended question. We're like, I noticed this. Tell me more about that. Or I'm seeing this. I'd like to know more, right? So it kind of follows a specific pattern of making an observation, following it up with an open-ended question, right? So I am liking number 4. Yes, 4/1. Yep, you guys, you got it. All right, let's see. Are we right? We are. Good job. Okay. Should we keep going? We've got 2 more questions left to get through. You guys are doing great. Okay, so number 4, we have a mental health question. All right. How are you guys feeling about mental health? I like it. I mean, obviously, I'm a psychiatric nurse, so it's kind of in my wheelhouse. All right. Let's see. The nurse is observing a staff member who's caring for a client who has schizophrenia and is experiencing auditory hallucinations. Which of the following statements by the staff member to the client would require the nurse to intervene? Okay, so again, a lot going on in that header and stem, right? So we've really got to read carefully to figure out what we're looking for. So in this case, we're looking for the statement that would cause the nurse to intervene, which means we're looking for a statement that would be inappropriate, right? Okay, so 3 of these are going to be correct and 1 is going to be inappropriate, and that's the one we're looking for. So before we do that, let's take a second to remind ourselves what we know about communicating with clients who are experiencing psychosis, because there's a few things that are going to be a little bit different, right? So I think it's easier to start off with the things that we don't want to do. So the biggest things that we don't want to do is we don't want to refer to hallucinations as if they are real. So we don't want to say like, what are the aliens saying to you? Where are the spies at? Why is that person trying to kill you? Like, we don't want to also convey to the client that we think that their hallucinations are also real, because it's going to reinforce that psychotic content for the client and make it feel even more real for them. But on the same hand, we also don't want to negate the client's experience. So we don't want to say things like, nobody's trying to get you, that's not what's happening, nobody's trying to poison you, because we have to remember that what the client is experiencing feels very, very real to them. So if we come in there and say, that's not what's happening, that's not real, nobody's trying to hurt you, they're going to feel dismissed, they're going to feel really suspicious of us, they're not going to trust us, and it might even make them really kind of agitated. So you might be asking, okay, well, if I can't go along with it and I can't tell them that's not what's happening, what do I say? So what we do is we make neutral observations. So we offer our own perception of what's happening. So we could say things like, I don't hear any angry voices, or I see Dr. Smith at the nurse's station, but I don't see any evil aliens. You know, I see Dr. Smith. And then we also want to acknowledge how the client's feeling. So we could say things like, I don't hear any angry voices, but that sounds really upsetting. That must be really frightening. That sounds really scary, because it is, right? So we want to acknowledge how that's making the client feel, okay? And then we follow that up by engaging them in things to distract them away from those hallucinations. So we might engage them in distraction, like playing a card game, doing a simple art project, because what we don't want to do is leave them sit alone with those delusions or hallucinations, because it's going to allow them to just get more and more wrapped up in that content. So we want to engage them in some reality-based activity that's simple and concrete. Now, if the client has some insight into what's going on, has some insight into the fact that they might be experiencing a hallucination, we can engage them in reality testing. So we can say things like, let's look around. Does anybody else seem to be hearing what you're hearing? Does anybody else seem to be fearing for their life? Do they seem to be seeing what you're seeing, right? So kind of just prompting that observation. We're not telling them that it does or doesn't exist. We're just saying like, hey, let's look around, right? We can also do things like competing auditory stimuli. So for auditory hallucinations, we might do things like turn on some music, engage them in conversation, turn on the TV, because it's really hard to attend to both internal stimuli and external stimuli at the same time. So it can help distract them from those hallucinations. If they're also experiencing auditory hallucinations and they have some insight, we can also help them tell the voices to go away. That has been a proven technique to help clients feel more in control of their symptoms. So with that in mind, let's go back to our question and see if we can answer this and figure out which of these would be inappropriate. So our first one is, why don't we go listen to some music together? Would that be appropriate for a client who is experiencing auditory hallucinations? Would that be appropriate? Yeah, absolutely, right? Because that's going to help distract them away from those auditory hallucinations. All right. What about let's go play a card game with the rest of the group? Is that appropriate? Yeah. That's also a good form of distraction, right? We don't want to leave them sit alone, like listening to these auditory hallucinations. So we want to get them engaged in a reality-based activity. Okay, and then number 3, I will help you and together we can tell the voices to go away. What do you think? Yeah, that could help them feel more in control of those hallucinations. And we don't have any reason to believe up here that they do or do not have insight, right? So if they did have insight, we could certainly have them do that. That might be helpful in decreasing those auditory hallucinations. And then number 4, what you're hearing is not real. You are experiencing a hallucination. What do you think? I think this often trips students up because we're like, oh, we're reinforcing reality. That's a good thing, right? But remember, it's a little different with clients with schizophrenia or psychosis, right? Because we don't want to directly negate that experience, right? So this we know, would that be appropriate? No, right? Because we don't want to directly negate that hallucination. Now, even if we didn't know that number 3 was appropriate, because that is a little bit more advanced, we definitely would know that this is inappropriate, right? So that would help us choose our answer. Okay, should we see if we're right? And yes. Okay, we've got one last question to do, and this is going to be a delegation question. So I know students often say like delegation and prioritization are tougher concepts to grasp. So I put a delegation question in here so that we can talk through this one. Okay, so we have a charge nurse who is supervising a registered nurse in the care of a client on a mechanical ventilator. Okay, and then we have the charge nurse should intervene if the RN asks the unlicensed assistive personnel, or UAP, to do which of the following tasks that we have described to us. Okay, so again, a lot going on up here, so we need to read this carefully. So we're looking for an action that would be inappropriate to delegate to a UAP. And depending on what state you're in, this might be like a CNA or a nurse's aide, right? An unlicensed assistive personnel. Okay, so 3 of these are going to be appropriate to delegate, and 1 of these is going to be inappropriate. So we're looking for the inappropriate one. So before we look, let's take a look at our 5 rights of delegation to help us remind ourselves kind of what we're looking for. So when we're looking for appropriate delegation, we need to look to make sure that we're delegating to the right person. So is, in this case, the UAP competent to do this task? Do they have the skill and the appropriate knowledge to do what we're asking them to do? Okay. Then we need to ask, is it the right task? And so is it in the scope of practice for the UAP to do what we're asking them to do? And is it a routine task with an expected outcome? Because remember, even though we're delegating that task, us as the RN are still going to be responsible for the outcome, right? So we need to be sure it's an expected outcome that we can evaluate. Is it the right circumstance? So is this client stable? So for this one, I always like to use the example of like client transfers, right? So we might often ask a CNA or a UAP to transfer a client from the bed to a chair, right? That would be totally within the scope of their practice. But what if this client that we're asking them to do it for has just come back from a total knee replacement and they've never done a transfer before? Well, in that case, we wouldn't know that that client is stable or not because we haven't assessed them yet. And so in that case, it would not be the right circumstance to delegate, even though it's within the UAP's scope of practice to do a client transfer. Does that make sense? Okay, so we need to make sure that that client is stable. We've already assessed them and determined that it would be an okay task to delegate. And then do we have the right direction and communication? So basically, does this UAP understand what we're asking them to do? Do they have any questions? And do we have the right supervision and evaluation? So basically, can we evaluate this task that they've done, right? So we need to be able to follow up because, right, we're ultimately responsible for this task that we've delegated. So we need to be able to evaluate the outcomes of this task. Okay, so let's go back and see if we can figure out which of these tasks, remember, we're looking for which one is inappropriate. So would it be appropriate or inappropriate to turn the client from, or to delegate this to to the UAP to turn the client from left to right side every 2 hours. Is that appropriate? Yeah. To move the client, reposition the client, turn them from right to left side so that they don't have skin breakdown would be within the scope of practice for a UAP. We can evaluate the outcome of that, right? Because we can see that their skin is maintaining integrity. So yes, I think that would be appropriate to delegate. So I'm going to say that would be appropriate. We don't need to intervene. Okay. How about number 2? Notify the RN when the client requires inline suctioning. Would that be appropriate to delegate? So I think to figure this out, we need to ask ourselves a couple of questions. So how would the UAP know when the client requires suctioning? They would have to assess that client, right? They would probably have to listen to some lung sounds, maybe look at O2 saturation. Okay, is it within the scope of a UAP to assess the client? No, right? It's not within their scope of practice to assess the client. That is the nurse, right? So can we ask them to let us know when they require inline suctioning? Well, no, because they would have to assess the client to be able to know when that needed to be done, and that's not within the scope of their practice. So I am going to flag this one here. I think that would be inappropriate to delegate, but let's take a look at our other options and see if we can make sure that that's the one we want to choose. So number 3 is perform passive range of motion exercises on the extremities. Is that okay? Is that within their scope of practice? Yeah, passive range of motion exercises, right? We can evaluate the outcome of that in terms of the client still having good range of motion. I would expect the UAP would have the skill and the knowledge to be able to do that. We're not asking them to assess anything, so I feel like that's appropriate, right? All right, and then we have our last option, to measure the client's respiratory rate and pulse oximetry reading. Is that appropriate? So I think where students get hung up is between number 2 and number 4, right? And what's the difference between these two? What's the difference between 2 and 4? Well, in 4, we're asking the UAP to measure respiratory rate and pulse oximetry reading. They're collecting data. We're not asking them to assess that data. We're just asking them to collect the data, give those numbers to us. Is that within the scope of practice of a UAP? Yes, right? But in number 2, we're asking them to interpret this data, right? We're asking them to interpret what that means, which is not within the scope of their practice. So what are you guys thinking? I like number 2, right? That would not be appropriate to delegate because we can't ask the UAP to assess the client, right? Okay, so let's see if we are correct. And yes, we are correct. All right. Well, you guys have done fantastic. Great job. I am going to leave you here with some links of where you can find us. So we obviously you can find us on NCLEX-bootcamp.com. We're also on, bootcamp.com/NCLEX, which you'll see here. We're also on Instagram and TikTok and YouTube, which we're on today. We have a Facebook study group, which you can see here. So if you go over to our NCLEX Bootcamp study group and you click that invite button, there's just a couple of quick questions you can fill out and be invited to our Facebook study group. And there's a lot of people over there studying for the NCLEX as well. We know it can be a really stressful time, so a lot of people really like that peer support as well. I do think Amber might be dropping some links for you in the chat if you are interested in signing up for bootcamp. We have a lot of really great study resources. We have study schedules. We have a very large Q bank. We have really great case studies with those video walkthroughs. And so a lot of students have said they felt it's been really, really helpful in studying for their NCLEX. So for all of you who are taking your NCLEX soon, I wish you all the very best of luck. I'm sure you'll be happy to have it done because, like I said, I know it can be a stressful time, a stressful season for you. So I wish you all the best of luck, and we will see you next week for another webinar that will be coming up. So everybody take care, and I will see you all soon. All right, bye.